Question number one, for post-COVID patients that are suffering from significant fatigue and daytime sleepiness, is an oral appliance a good treatment for their sleep disorder, or should they be using CPAP? How do we help these patients make that decision?
Here, you want to make sure that they uh, sleepiness in the daytime and fatigue has a degree of sleep disorder breathing. I mean, it's a good bet there's something there. Uh, and if that's the major target of therapy, then you need to follow up that this is something they're going to use. And there are some patients who won't use CPAP, even if they have insurance that pays for it and they purchase it. So that's not an effective therapy. And so that's a several step answer to the question, which is better? Well, in the bottom line, it's what they're going to use. So if they buy CPAP but don't use it, that's not a solution. If they have an oral appliance, it's much more desirable. It sits right next to them on the bed. It's easy to use. It doesn't have a mask. It doesn't have humidity. It doesn't have heater. And it has all sorts of reasons why they prefer it. Well, that might be the better solution. So it's really what counts on what works, and things that don't work are things that aren't used, that are sitting around. So that's my nuance to answer to that question. And this is a pretty common question right now.
Okay, thank you. Number two, are patients with untreated sleep apnea at higher risk of cardiovascular disease or stroke, or both equally? Is the risk, say, 4 times or 7 times higher with untreated apnea?
Okay, that's an interesting way, because the numbers don't fit so simply to say twice as much, 4 times as much, because it depends on who you start with. So if you start with patients with no other diseases and they're 30, 40, less than 50 years old, so the younger patients who have sleep apnea, there's no competing diseases, so the factor is actually higher. Once you add in diabetes, hypertension, just simply age, having smoked for 40 years, you've got to be old enough, you've got to be around for long enough to have had 40 years of smoking. So you have to have a certain age. There's competing other causes for cardiovascular disease. So the factor gets lower because there's other things going after the stroke and the heart disease causing in the patient. So that's a more of the factor gets lower, but however, the chances of having something go from less than 1% when you're young, even though sleep apnea may make it 10 times more likely, 10 times 1 in 1,000 is still not a lot of risk. Then you get someone who's 65, has diabetes and high blood pressure already, and you calculate their cardiovascular risk of having a heart attack in the next 5 years, and then you double it with untreated sleep apnea, their risk goes from perhaps 30% to 60%. And that's a big difference, even though it's only a factor of 2. So the numbers aren't just factor of 2, it's doubling what risk. And you can take this away. The concept of risk is that, I mean, if you wear a seatbelt in a car, it cuts down your chance of being injured. But if you have a parked car, do you wear your seatbelt? No. Why? Because the chance of an accident causing injury is very, very low. Maybe a bus will go out of line and hit you, like it could hit a fire hydrant. Chances of an accident causing injury is very low. And everyone wants to put on their seatbelt when you're going over the speed limit on the highway. Why? Because your chance, if there's something going on, that you could get injured and could get thrown out of the car. And so it's very clear that the seatbelt's helping you there. Why? Because it cuts your risk down when the risk is already high. And so using the treatment for sleep apnea is equally valid with a big increase in factor of risk with young people with no other risk factors. So let's say it's 10 times more if you're 35, severe sleep apnea, and you're going to treat it, but you're cutting down your chance from 1 in 100 to 1 in 1,000, which is a 10-time factor. But the chances are you're not going to have a complication at that age. Whereas if you're older and have other risk factors, although it only doubles your risk, doubling 30 to 60% is a big double. So I really want to reiterate that that's how that risk function works.
Okay, thank you. You may have trouble with this next one because we dentists always have to have a specific appliance. So,
Yeah.
do you have an oral appliance that you recommend for your patients? I know what you're going to say. The one that works.
Yeah, well, that's right. But I do have preferences within what I know of the currently available oral appliances. So the Somnodent has basically, I've seen two out there. I'm not sure. I think they're still producing the regular Somnodent, the one that looks that has the adjustable screws on the side, the stops. It looks like the patient has teeth that are pink. There's the Somnodent Avant, and I do think it's an advantage listening to my patients. Why? They can speak with it in their mouth, whereas the other one they can't. It's too rigid. There's no mandibular mobility. So if they feel that freedom, they're more likely to use it. And the Pantera is a Canadian a nylon model. Patients I find quite like it. It's very resilient. It does not tend to break when you drop it on a cold floor in a cold bedroom, unlike the Prosomnus, the rigid plastic devices. But anyone who's got a dog at home, they can chew up their devices. So I've had about 10 patients over 20 years who've lost an appliance to a resourceful puppy or dog that jumped on the bedside table and chewed on something that smelled like their master. You know what I mean? So I do have, it's the ones with mobility and allow speech at night. I find the patients don't feel so constrained, and so they're more encouraged to use it. And remember, these are patients who often said no to me, and my prescription is CPAP. So they're the kinds of people who don't like constraint to begin with. They don't like ties either. So you can sometimes see them coming.
Well, we've all heard the dog story, and I don't think there's a dental office in the world that hasn't replaced a number of them. Just 2 days ago, a patient that we treated about 3 years ago called in a panic because he lost his appliance, and he didn't want to tell us, but his wife fessed up. And it turns out he has a bit of a urinary problem where he visits the toilet a number of times. And this particular evening, somehow it fell out of his mouth and into the toilet and got flushed down the toilet. And he was all in a panic. And I tried to explain to him, it might be more important to go home and get a Palmer to see if you can get it out, because this was a Pantera, so it's quite thick. And I tried to explain to him how the size of the pipe is going to constrict to a point where it may get stuck, and you may have a bigger problem than an airway issue. You may be drowning yourself. And I asked him if he lived in his home or an apartment. He owns the property, so he rushed home, and I don't know what the outcome is, but these things do get lost a lot. Next question, and evidence that your students listen to you. This is about medication. What are some examples of meds that a sleep physician would prescribe for patients that are still experiencing excessive daytime sleepiness, even though their oral appliance has achieved an AHI of less than 10? So meds for under AHI of 10 oral appliance. What specific drugs, I guess, is the question.
Yeah, so this is my job, and this is why I get to know some patients and see them much more frequently than a sleep apnea doctor would, because they need represcription. The medication that is probably the longest out with the best evidence is called modafinil. Its name is Allertech as a trade name. There's another version of it, an isomer available in the States we don't have in Canada, called armodafinil. You might see it in the literature, but we don't have it in Canada. And there's some new ones that have come out. One's called Sunosi. It's quite expensive. It may be more effective. And it's called Solriamfetol for generic name. And an old medication that's been used since the Christian Guilleminault, the late neurologist who did a lot of research and teaching at Stanford. Before they had modafinil, they used Ritalin, and it's the lowest cost medication for this. And some provincial formularies require using Ritalin to then fail Ritalin to move and to then pay for modafinil and perhaps anything else. So those are the medications that are there. Ritalin may treat some comorbid attention deficit, which is not that rare. So There's reasons why patients actually quite like Ritalin adjusted to avoid side effects over modafinil. And from my experience, this may be one of the reasons.
Okay, thank you. Next question. What is your opinion about a CO2 laser improving snoring and sleep apnea?
Okay, so that is a kind of surgical instrument. I put it that way because the CO2 laser is one way of managing the fleshy upper airway that often leads to sleep apnea and loud snoring. The problem with all of the surgical approaches, the patient needs to be well chosen, and they need to be retested later after a certain amount of time of healing, and then retested later on because there's early and late failures, or you might say non-responders to therapy. And I don't categorize myself, the CO2 laser, as different or advantageous for treating the sleep apnea. It has its advantages as in your OR for all the reasons why you might choose it. But the issue is that although you may be able to cut out some tissue, you just can't cut out the tongue. If the tongue's the cause, you have to find another way.
Okay, good, thank you. Is there a home test available to help calibrate an oral appliance in Ontario?
Sure. It's called the Braybon monitor, comes from Ontario, produced in Ontario, and not paid for by OHIP. I can't speak about the politics of medicine in Ontario, but they are an outlier in Canada in that they do not reimburse home sleep studies. And that's very different from the environment all over the world. Sleep studies are generally now mostly done as home sleep tests, and if it doesn't make sense, then you move to polysomnography. So it's something that I think has to do with the history of sleep medicine in Ontario, not necessarily what should be done in the future. And that's often because of politics and other interests that keep things going the way they are.
Politics, Ontario? Doctor, you're fooling me.
What do I know? I'm just a doctor.
Okay. Is there a difference between dreaming in REM sleep versus delta sleep?
Absolutely. Well, there's typical dreams. There are dreams in all stages of sleep, including the stage one when you're just falling asleep. The most often when a dream is with REM sleep, it's a colorful, complicated story. And often crazy things go on, or boring things too, but people don't like to remember or tell about boring dreams where they were cleaning the dishes and they looked out the window and they saw a cat that looks like Garfield that then chased a cardinal and a sparrow, and that's the end of the dream. You know, that can be a dream, but those tend not to be that interesting, and so people don't tend to remember them or talk to you over coffee in the morning, this kind of thing. It's the ones that involve chase or violence or something that might obsess them because it's interactive with something they may be psychologically working out from childhood or whatever. The dreams in sleepwalking or delta sleep tend to be colorless in several senses of that word. So they tend to be sort of black and white, faceless, perhaps menacing individuals. And I had to get out of there. A feeling. And it doesn't make any sense. There's no story necessarily. It's more of a feeling, of a scene. You might say a photograph or two, or no more information than you might have from a GIF. The internet pictures that move, that are blurry, not very detailed, and certainly don't seem to have a clear beginning, middle, or end.
Okay, thank you. Now an AHI question. Statistically, women have half the prevalence of men. But is that really true? Or is it that AHI is better suited to diagnosing in men and not in women?
It's a good question. I think the sleep apnea measure called the apnea-hypopnea index will likely stay. There's been some good technological push to include upper air resistance syndrome and then bring it in and bring it out. And then really what seems to keep it around is now insurance companies want to know it to decide if they pay for something. And so that's going to very well guarantee that all the tests are going to have to generate that number one way or another. In women, the tendency with age is that girls before puberty and boys tend to have an equal chance of having sleep apnea. It then differs when they become physically fertile, so go through the tenor stages, breast development and all that, and stays less than men, depending on how you measure it. But all the research always finds that there's about, let's say, about 1-to-2 ratio of women to men in a group where you study everyone, including the people who obviously don't have it. So you count the ones who don't. And then it comes back together after menopause. So there likely is something to do with the shapes and the hormonal control of breathing, as well as the reactivity of the upper airway. And I do understand that because I've seen a lot of research try to categorize and really count the respiratory disturbances that affect pregnancy, where that's where the female hormones that are highest in the life of a woman, usually, progesterone especially, and the breathing changes and reflects that. And so they tend not to have desaturations, which then help to count to hypopnea. They tend to have more of the milder, what we say, respiratory events that disturb sleep. And those aren't classically in the AHI, they're the upper air resistance thing. So I do think there's an argument there in how the counting's done. I'm not sure how that's going to change in my lifetime, what we clinically need to use to manage 28% of the population between age 45 and 85. So it's a good question, but it depends on the female male gender at the stage they are. So there's before puberty, it's around equal. After puberty till menopause, there's a difference. Then after menopause, women catch up quickly to the rate that men have it. And that's using all the AHI for all those studies from the 80s through to more recently.
Okay. This next is a technical question, and I'm going to preface it by asking you to maybe think about answering my concern. And it's about apneas and hypopneas. And I could never understand why they were given equal weight. In other words, one apnea and one hypopnea equals 2. When I treat patients, I see a lot of the apneas slide off, and then we work on the hypopneas, but the numbers don't change much. And the patients are feeling great and they love you and da da da, but no, you're still at 17. So that's something for you to think about. I wish there was some kind of a ratio of 3-to-1 or 4-to-1, whatever the severity index would indicate. But this specific question from a member is there a chance to have more apneas than hypopneas in any one case?
Yes. For example, patients with high loop gain tend to have more apneas when they have their diagnostic sleep study without any treatment. Whereas patients with low loop gain sleep apnea, maybe typically the obese or people with just a very big tongue and they sleep through all the respiratory events, they tend to have more hypopneas. If there's a difference there. Your observation when people are partially treated, I also pay attention to those changes, the shift away from apneas, the capacity to sleep on your back more, because the sleep apnea index on the back isn't 60 like it used to be. It's now 17. And so they spend most of the night in the back. And in the first sleep study, they spent only 40 minutes. And so they had a lot of apneas, but not much time. You see, so you're getting somewhere, but it's not, you're not over the finish line. So and they're putting the apneas hypopneas together came from a small group of researchers who were trying to define what is what and set a standard in the late 90s, early 2000s. So that may change down the line, but I'm not sure how fast it's going to change.
Like we might have an AI or an HI as opposed to an AHI?
Yes, well, that's already been counted. If the machine will put it out,
Right.
they do.
What are the ways to diagnose or assess upper airway resistance syndrome?
Okay, that needs polysomnography. It can't be really well defined and measured with home sleep studies because the upper airway resistance events are, from the history of it, crescendo snoring. So you have snoring that gets worse and worse and worse, but the breathing volume doesn't change. So they don't have a hypopnea. They don't breathe less. There's no big difference in the oxygen either. And then they wake up. And you need the polysomnography with EEG to see the sleep, 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 wake, back to sleep, called the arousal. That comes with the progressive respiratory effort, which has its way of monitoring with a preferably the nasal pressure cannula on the non-invasive sleep studies that almost everyone's doing nowadays. So it has to be polysomnography. You can't go halfway with a home sleep study. And there are indirect ways of suspecting it, but not diagnosing it on a home sleep study. And that requires usually the visual scoring by a technologist who understands what they're looking for. And then illustrates it by printing up some things and getting the doctor like me to then prescribe polysomnography to prove what they think was there. So you're seeing a shadow of the respiratory disturbance, but you're not actually defining it enough to make the diagnosis. So it's polysomnography because you need the EEG.
Would modafinil help post-COVID patients dealing with EDS?
I would
Excessive
think
daytime
so.
sleepiness.
I
Okay.
would think so. And in the hospital, when some patients were sleeping and sleeping and sleeping, and they're out of the ICU, they don't need much oxygen, but the physiotherapist is having a lot of trouble getting them out of bed because every time they come by, they're too shy to wake them up. They wake them up, they try to sit up, and they go back to sleep. I put them on Ritalin because that's on the hospital formulary, whereas modafinil is not. To try to just give them a way to go. If it's not a chronic long-term problem, this is a temporary prescription that may last a few months. It may be abridged until they can get moving, get into some routines, and redevelop what they might have lost in the ICU experience, which is they've lost their day-night cycle, circadian rhythm, which helps daytime alertness and consolidates sleep at night. So I think that not only modafinil, but modafinil at a particular time of day, so in the morning, to help restart the day-night rhythm.
Okay. Why do people start snoring again after 6 to 12 months of appliance wear?
They may be gaining weight. They may be starting to drink again. There's all sorts of behavior that is part of the normal human being. So I really think that you have to sort of pay attention to that and ask if something else has changed. Also, these appliances, they have a certain amount of elastic adaptation. So although you set them at a certain millimeter setting, they are made out of flexible materials that may give over time. So I think that this may be also part of it. So there's all these factors can be there. I don't know the individual, but I wouldn't be surprised to hear that and thinking that you may have to adjust up a notch or have a good conversation about why this is happening. It may reflect that they're sharing a bottle of wine with their spouse 5 nights a week. Very, very common pandemic thing that's come up.
Yeah. Well, it's for medicinal purposes, I think, isn't it, doctor? Red
Well,
wine is good for
you can have side effects called the wine belly.
That's right. That's right. Is it abnormal to rarely remember your dreams, or is this the way we were built ancestrally? That makes sense?
No, it's the normal thing is to not remember your dreams in our society. Some societies worship the dreams. They use the dream as a way of communication. Everyone is concerned about what they're dreaming, and it's important to their belief system. It's not the European sourced Canadians who have this belief, but many people do, and especially those who allow themselves to sleep in the morning and then wake up, maybe do something basic and go back to bed. That's a key time when you can actually mix your waking with the dream time and become conscious of what's going on in your dreams, because you need that bridge between the dream state and the wake state to remember. And if that goes on regularly enough, then you develop the capacity to remember your dreams, and then access them with whatever understanding or interest you have in them. But hanging around in bed until you really finish sleeping, that's the best way to get a chance to remember your dreams.
Okay, thank you.
One of the questions that I would like to pose to our speaker today is the fact that as your practice ages, you start to see patients who have more and more tendency to have glaucoma. And it's really interesting that glaucoma and interocular pressure are considered, the interocular pressure is a major factor in it. But one of the things we don't see is an increased focus on getting ophthalmologists and optometrists to be aware that sleep apnea can be a factor in the deterioration of the eye.
Dr. Baltzen.
Yeah, so I have a very interested ophthalmologist, so a doctor who does surgery. He does cataracts and glaucoma surgery, and he's very interested in the link. It's hard to know, do the two ride together because there's a genetic link that people who have the genes to develop sleep apnea and glaucoma, it's shared, or is it because of something to do with sleep apnea where the low oxygen then changes something in the adaptation that happens not only in the kidney for hypertension or the vascular system, but also in the eye, changes the glaucoma regulation of the flow that then is changed and leads to glaucoma. So there, I'm not sure what is the cause, what is the chicken and the egg, you might say. But the two do go together, but it's not a hard and fast rule that people with sleep apnea have to have glaucoma and vice versa. That's also there. So
Good,
Thank
you,
you.
Mark. So thank you, Mark. On behalf of all of our members, thank you so much for your contribution. And thank you folks for attending tonight. And we'll be back together in about a month. Thanks so much. Night, folks.
thank you, David.